My name is Odi Ehie. I'm a pediatric anesthesiologist by trade, and I did my pediatric anesthesiology fellowship there at Lucille Packard. So I am going to first just give a little bit of a disclosure. I'd like to say that I have no disclosures of note except for what you see there, which is the FAIR Research and Education Grant, for which some of the results that I will be going over in my presentation today actually funded. Other than that, I really just wanted to focus on some of the objectives here, just so you have an idea of the breakdown of what I'll be discussing. Um, Really, I want to focus on some examples of allyship and how we can model that in our practice. And I'll certainly go into the implementation of the DEI curriculum that I was able to do at UCSF, and then also hopefully rounding that out with some actionable ways that we can implement sponsorship, mentorship in ways that does mirror allyship. And so I hope to also make sure that we leave enough time because I really do believe in Q&A and just the power of being able to discuss ideas together as well too. First and foremost, I thought that it would be great to at least have a little bit of a painting of a picture of the person who's speaking to you today. You certainly have heard Dr. Krishna speak to some of the things that I've done in the academic world, but I think it's really important when we're talking about these topics such as EDI that we do so also knowing who's the person who's speaking about it. So on a more personal note, I like to speak about my history. My family actually moved from Lagos, Nigeria to Montgomery, Alabama while I was 8 years of age. So I spent a good amount of my time in Lagos, Nigeria before I was here in the States. I also went to a high school in Montgomery, Alabama, but I'm also proud to say that I'm a pipeline baby. I did a pipeline pathway program called the Healthcare's Opportunity Program and between high school and college in Alabama. And that really galvanized my interest in wanting to pursue medicine when I otherwise hadn't really been exposed to it or had any connections to it. And so I also come from the space of having been a product of it, really, really wanting to highlight the impact of these type of programs that exist that we may or may not be in um, uh, collaborating with. Also, so another part of my history, if I can just get through this next slide, there we go, um, is that I did go to a historically Black college in New Orleans. I went to Xavier University, which I'm a very, very proud alumni of. And from there, I did another pathway program. I did the Gateway Summer program. And it was through this program that I was able to have the sponsorship that I would not otherwise have known that I would have needed down in my medical career pathway. I'll speak a little bit about that later. I went to become a first generation medical student at the University of Wisconsin-Madison. And if I'm being vulnerable here, I would like to say that I certainly had a fueling of my imposter syndrome in this space. But I was able to, find mentorship. And it was through mentorship from individuals such as Ruth Goshen and also Dr. Fritzling Montalmont, where I was able to get into the NYU anesthesia residency program. And then through further mentorship, was able to get into Lucille Packard for my pediatric anesthesia fellowship. And I have a picture there of Dr. Corey Scher, who was influential in being supportive of me during my residency program. So I have been at UCSF for about 8.5 years now. And now I'd like to go and segue from my personal journey to why we are here and why we care about promoting a diverse workforce in the spirit of allyship. I really like to let the papers tell the story. This paper that I have here is basically a 16 large-scale study that relates diversity to a financial as well as quality outcome, and it demonstrated positive associations between diversity as well as positive associations with quality and financial performance. Essentially, it was a meta-analysis that showed how patients generally fared better when they were cared for by a more diverse team. And some of the components of the paper highlighted the improvement of innovation, team communications, and risk assessment. So moving further along, I just wanted to highlight that there are several studies that demonstrate that racial and gender concordant care have been quite impactful with higher associations of improved communication and higher quality of care. And this in itself also underlines the very importance in promoting a diverse workforce. And again, there are many articles. These are a few that I've been able to highlight, but we can certainly share these with you later if you wanted to go into them. But really, to me, the most profound paper here is the Saha study. And this Saha study was a web-based survey that was administered by the AAMC to over 20,000 graduating medical students. And the results demonstrated that white students within the most racial and ethnic diverse quintile for that student body representation, they were more likely to rate themselves as highly prepared to care for minoritized populations than those in the lowest diversity quintile. So in other words, when you had student bodies or trainee programs that had diverse representation, whether it's from disadvantaged status such as disability, race and ethnicity, and in this specific study, they looked at race and ethnicity, you actually ended up having a more trained population within that program, whether it's a student body or the residency program that felt like they could care for a more diverse community, especially with folks in the program that may have intersectionalities that they get to learn about in that space. How powerful is that? So, as we as a community, we can promote allyship actions. And when we think about how we can do it, I think we first have to think about how we define privilege and power. And the thing about privilege is that you really can't do it without identifying power. So that's why I put it together. Now, when we talk about privilege, privilege is comprised of advantages that are conferred on individuals based on membership or assumed membership in a dominant group. Whereas power operates across many social identities, such as race, gender, age, ability, and social systems such as education, healthcare. And it's being positioned within the dominant or privileged group that affords power in order to use that towards allyship. And so as I move forward, I really wanted to kind of get into um, what is true allyship. When I ask about what is true allyship, I really do think it's important to also highlight what performative allyship is. We've heard this buzzword many times, countless times over the past several years. So what is performative allyship? Well, it's when someone from a non-marginalized group professes solidarity with a marginalized group in a way that is not helpful to the marginalized group. And it's basically that virtual pat on the back or that virtue signaling. Examples of that could look as the mindset of, well, everyone's doing it, so I have to, or I'm going to do some more virtue signaling around this, or perhaps centering yourself. Whereas authentic allyship is going to be really focused more on educating oneself, examining one's own privilege and using it to help. Basically, coming with the thought process of it's not about you, it's really about this individual that I'm trying to elevate here. So, this actually transitions me into my next slide. Now, I know I have some anesthesia training slides, but this is actually relevant to surgery in the sense that our training programs and the representation that we have within anesthesia and our perioperative training programs is quite parallel. So the only, I think, exception is OBGYN. So I do think that this is still relevant in trying to get to my point. So I'd like to transition again to looking at the AAMC and ACGME database from 2021 to 2022. This basically cross sections all of those. So looking at the stage of medical applicants all the way to professorship. And these have been aggregated by gender as well as race and ethnicity. But let's start with gender first. And I really do want to apologize that these databases currently only reveal or reflect binary categories. And this is a testament that further inclusivity needs to be encompassed around our databases in order to be able to delineate these as well too. But just looking at what we have here within our gender, if we look at our US population, you see that it's pretty evenly split. And when we look at our medical school matriculation, the applicants there and then the students that come through, again, that's actually quite reflective. In fact, it's actually a little bit slightly more female than it is male. But then when we look into who's applying to anesthesia, we see that there is a drop off, right? We see that there is a drop off, and the the female population in these categories are lower, and then even more so lower when we look at who's an assistant versus an associate versus a full professor. Now, let's also look at this with regard to race and ethnicity. I again always like to apologize because I know these are big categories, and we're really not doing our due diligence by looking at subcategories, especially when we're thinking about the Asian population. Um, but let's look at what the databases of AAMC and ACGME have, and we're going to extrapolate based off of that. So when we look at the US population, we see that we have Asians that are representative around 6%, Blacks around 13%, Latinx around 18%, and whites of 60%. And when we look at the applicant pool, though, we see that there is a drop of Black and Latinx individuals in terms of medical school applicants as well as medical students that are lower compared to the population already. So there's space for recruitment there and space for more pathway programs and influence and getting more of a pool in that regard. But then also when we look at the people who were applying into anesthesia, and this may be very true with general surgery, it's lower compared to the other pools. And so who ends up matriculating in terms of our residency program ends up being quite low in terms of what's representative of our national population or population that surrounds us. And that's also even more prominent when we look at what's representative within our academia in terms of professorship. We have a low percentage of Black and Latinx professors as an assistant and associate professor level, and then even much lower in the in the full professor level. So something to consider when we think about, well, what's the makeup within our surgery training pipeline? I think this is something that would be really interesting to showcase and look at if you haven't already. So this now brings me to the Highline Diversification Initiative. I really speak to what the results are, and then I get into what they did. But when we're thinking about, well, what are some of the things that we can do in order to help really influence these pipelines and influence who's recruited and who ends up staying, we can look at some initiatives that have actually already been implemented not too far across the bay. This is in Highland Hospital in the East Bay. And when they implemented this initiative, what they found was that there was a twofold increase in Black and Latinx residents over 10 years after the initiative was implemented. Um, and then also, Middle Eastern residents increased almost fourfold after the initiative was implemented. However, there was very little increase among residents of Indigenous descent. So there's still more work to be done there. So what was the initiative? Well, first and foremost, they have no USMLE filter. I know that that's something that's very controversial. In fact, with our step ones being pass and fail, and our step twos being a little bit more utilized now in terms of who gets in our program in a space where we don't have a USMLE step one. That's something that is certainly deserves a lot more conversation. But what they did also do, though, was that they looked at the increased weight of a Gestalt score, basically meaning that they looked at the theory of perception and understanding. They looked at how this student was faring on the bedside and how their clinical knowledge and the way that they're implementing it, how they're presenting it rounds, how that looked, not just looking at the number. They had a diversity committee, which allowed them to be a lot more intentional in terms of, well, here are our mission goals. These are what our initiatives are going to be. This is how we're going to standardize our interview questions in order to try to be as equitable as possible. And they also had an attending and resident buy-in as well as a diversity applicant week. So when we're thinking about true allyship actions, I really want to reemphasize that in order to increase a diverse workforce in our specialty, we really have to work to increase recruitment as well as retention within our medical schools and residency and training programs. Um, in terms of pipeline programs, which is again something I'm a huge champion of, I just wanted to give a few examples of what we're doing here at UCSF. I know that at Stanford, they do, within at least the anesthesia department, they do what's called the Project Lead the Way, which has been really impactful. I'm not sure what other programs that exist there, but I know that Stanford's been really, really amazing with some of the pathway programs that they've implemented over there. Some of the things that we do here within UCSF is that we have what's called the Students Capturing the Operating Room Experience. We do that for middle school students. And then we have our Helix Summer Medical Program that we do for high school students. And also we have our URI program, basically our undergraduate research internship program, where we have Berkeley students who come from disadvantaged backgrounds matriculate into our summer program where it's built in with didactics, it's built in with research mentorship, they have a project, and then they also get to shadow an OR based on what specialty that they're interested in. And I think that the other thing when we're thinking about true allyship actions outside of just these pathway programs is really thinking about how we can get our diversity committee. First of all, do we have one? And if so, how do we get them more involved in other committees that really control that recruitment and the retention piece? So maybe perhaps their involvement within the residency selection committees, within the fellowship selection committees, making sure that there are conversations being had at these junctures can be really impactful, influential, and making sure that the numbers are reflective into who we're serving within our community. So now, even more importantly, in discussing recruitment, I really want to focus now on how do we keep diverse groups of trainees and faculty within our specialty and practice. This is, I think, probably the hardest component, because we do know that there is a higher incidence of faculty and residents and trainees leaving academia in comparison to those who are non-marginalized. So what are we doing about that, or what can we do about that? Um, and one of the ways I think that can be very systematic in approach is just having mentorship and sponsorship at the forefold. And so one of the reasons that I like to highlight that is just looking at some of the studies that have come out. There's one that really looked at it was a grounded theory qualitative analysis of 20 Black residents in a Northeastern medical center. And when they were asked what their experiences were like in that space, they spoke about discrimination, they spoke about differing expectations, they spoke about social isolation, and even career consequences should some of these come to light. And this really then begs the question, okay, so not only do we know that there are different experiences that our trainees, maybe from different backgrounds, are coming in and having, and what can we do about that? But also, more importantly, well, what is the impact of mentorship? I think we all know this, but then we even have studies that have demonstrated this, where when they looked at a mentorship in the pursuit of academic medicine careers, this is a mixed method studies of residents in diverse backgrounds. And they found that most respondents reported that mentorship was important for entering academia, again, not surprising, and that 70% reported having sufficient mentorship to pursue academic careers was really impactful as well, too. The other component is that they looked at three themes around mentorship. And the one that I thought was interesting was the quality of that successful mentorship model. Other things included perceived benefits of that mentorship and also the value of racial and ethnic as well as gender concordant mentorship, which may not always be able to be modeled depending on the composition of our institution. And so not only relying on this, but also the value of this when we are able to have it. And also, there's another study that looked at the impact of active mentorship. Again, this was a result from a survey of faculty in the Department of Medicine at Massachusetts General Hospital. And again, not surprisingly, they found that the quality mentorship or quality of that mentorship significantly and substantially impacted both academic progress and job satisfaction. So when we're thinking about mentor-mentee dyads, I think the three philosophies that I like to bring into when we think about allyship spaces is the establishing of that relationship, the enrichment of that relationship, as well as maximizing that success of the relationship. And when we think about establishing that relationship, one of the key pieces is to ask our mentors, or as mentors, if we ask ourselves, are we engaging in implicit bias training, or have we done so? And when was the last time that we did that? And also, as mentors, should we be considering seeking mentees from backgrounds that are different from their own? We know that mentees can sometimes gravitate to those who share similar backgrounds, but perhaps when we know that there's already a trend where we don't have enough representation in our trainees and our faculty, perhaps being more intentional and making sure that there's non-concordant pairings as well too in that regard. And then also thinking and encouraging our mentees to consider early involvement in professional medical societies. This is again where they can get inadvertent exposure to non-concordant as well as concordant mentors. And then formal mentorship programs, which can then help pair those individuals, both female physicians as well as those that are marginalized, with senior mentors, which can be really impactful in one's career. Now, when we're thinking about enriching the mentorship relationship, I think the one thing I want to highlight here is the importance of engaging in open and respectful dialogue about life expectancy, like life experiences, life and culture, as well as inequality. I think bringing this to the forefront allows for authentic um, and and conversations that are vulnerable that allow for a trusted relationship when our mentor-mentee dyad. The other thing I want to highlight here is the importance of cross-cultural competency training. I like to really say it's more cross-cultural humility training, more so than competency, but really making sure that we are engaged in education, that again, we don't expect ourselves to be fully competent, but we certainly expect ourselves to attempt to try to understand and to abreast ourselves with the knowledge and educating ourselves about what's going on around us, especially when we're interfacing with different individuals from different backgrounds. Now, in terms of maximizing a relationship, the two things that I think are the most important here is the group should define your goals and then also discussing how to select for opportunities that best fulfill that career and that goal. So that's the mentorship plug. I'd like to then now move to the sponsorship plug. And when I speak about the sponsorship plug, I really do want to talk about how I was sponsored in a space where I was advocating for a DEI curriculum well over 5 years ago. And there wasn't that much space around that in a time that I was trying to do it. And so I think that in addition to those type of allyship actions like mentorship and sponsorship, and I'll go a little bit more into my sponsorship pathway, I think that also we should be thinking about diversity training in that we also systematically call out inappropriate behavior. We use inclusive language. We create a space of inclusivity in our working environments. And so that we do see a less drive for our residents, our trainees, as well as our faculty who may be coming from marginalized backgrounds leaving. So those are some things I really want to highlight. But now let's go back to my story of sponsorship. Again, when I tried to implement this program, which now I'm finally getting into, I certainly met, it was met with a lot of resistance because of the first question that came up was, well, who's doing this? ACGME, there's nothing within ACGME that says that this is something that we should be doing. Are there any other institutions that are doing this? We have such little time with our trainees. Like, how do we justify that we are going to do this when there's very little time for them in order to do what they need to do to demonstrate the skills that they're supposed to acquire? And so the reason I felt so passionate about it, I think, was I was lucky enough to be what's called a Bridges Coach at UCSF. A Bridges Coach is essentially one of 40 faculty members that is essentially appointed to be a mentor and a coach to medical students. And by doing so, you basically get to follow them until they graduate medical school. And as a Bridges coach, I had the opportunity to participate in a Differences Matter orientation where the medical students receive basically their first week uh, of training where they focus more on conversations around identity. They focus on conversations around microaggressions, allyship, and I'd never been in a space where this had happened before. And concurrently, we have faculty and staff at UCSF that undergo what's called a DEI champion training, a full 8-hour training that focuses on unconscious bias, allyship, microaggressions, identities, all these different things. And I wondered, wow, we have this synchronous space for our medical students to do this. We have it also for our faculty. Why don't we have this for our GME learners? This is so important for them to do. And this is why I pushed back. And finally, I was able to be sponsored and given the space to be able to implement this curriculum. And in so doing, I use current 6 steps to do this. And so the first part of current 6 step is to really just identify, well, what's the general need? What's our general need assessment? And why I decided to really push this program was this article out of my literature search was to me the most impactful. It was just the most interesting. And that really, I think, drummed home the point. This is why we need to do what we're doing. So this is you all may be familiar with this because if this is based off of surgery. But basically, the New England Journal of Medicine put out a paper back in 2019, and basically among 7,400 surgical residents, 31% reported discrimination based on their self-identified gender, and 16.6% reported racial discrimination. Furthermore, patients and patients' families were the most frequent sources of gender discrimination and racial discrimination. And so when I put this to our residents and asked, how do you feel about this? Do you feel that you are empowered with skills in order to be able to navigate when this happens? Because if this is happening, the answer was no, they didn't feel empowered. In fact, I then did my step two of my current six step, which was to do a targeted needs assessment. And in so doing, I actually did, I gave about 50 surveys. I got 41 responses. I did this over a 2-year time. And when I asked them, well, then what would you want to see in an ideal training program? One of the responses was that they would want to focus on learning how to respond and take actions against bias and microaggressions. They want to uh, have skill acquisition around recognizing microaggressions and other forms of racism. And more importantly, they wanted an iterative curriculum that continues over a period of time. And if not just years, they don't want a one-stop shop and done. They want something that is constantly molding and growing and allowing for them to progress. So then this led me to step three of current six steps, which was the goals and objectives. So coming up with how are we going to implement this? So I use a theoretical framework where I incorporated critical race theory, various intersectionalities, minority stress theory, also gender identity theory, and then also thinking about transformational learning, especially with adult learners. And so what is transformational learning? Basically, that's the theory that's used to focus on the idea that adult learners actually can adjust your thinking based on new information. And so this workshop was designed with these in hand and implemented over the course of a year with different steps in place. And leading to my educational strategies, which is the fourth step, I focused on recruitment of co-facilitators from different disciplines. I knew that being in the DEI space, having undergone different workshops with folks from Department of Internal Medicine, from the Department of Pediatrics, from the Department of Emergency Medicine, from the Department of Surgery, I knew that there were a lot of leaders who were interested in facilitating workshops such as these. And so I was able to bring them all together in implementing this workshop for anesthesia residents. And it ended up expanding before I was able to pilot it. It ended up expanding to doing this workshop not only for anesthesia residents, but also for surgery residents. In this educational strategy, while you have facilitators that are already trained in doing, in talking about concepts in the umbrella of EDI, I knew that we also needed a trainer trainer session that looked at the specific concepts that we were going to go over within our workshops. And so our workshops really span an unconscious bias workshop, an allyship workshop, and a microaggression workshop, which I'll get into later. But having actual conversations that really standardize the small groups and making sure that there was spaces of minimizing harm and making sure that we were prepared for the difficult conversations that would come up based off of our experiences in other workshops. That was really important in making sure that we minimize that. We had facilitator guides so that everybody who was co-facilitating could really make sure that they were nice and prepared. We After having done this with a mentor of mine, they came up with the recipe of a 1-to-5 ratio. So having one facilitator to a learner, a group or pool of 5 participants really allows for variable perspectives, but really more so small enough of a space to allow for those residents to share vulnerable conversations and to make sure that we hear everyone's opinion and everyone feels that their opinion matters and is valued and there's space for growth and learning in those spaces. And so we did that, and we also made sure that it was interactive. We had our PolyV feature utilized. We had other Zoom features utilized. We used relevant case scenarios, especially in the intraoperative space, because if you look at the literature, a lot of this literature is done in the non-perioperative space. Internal medicine tends to be a leader in it, pediatrics as well too. And so their case scenarios tend not to be in a space within the perioperative environment. And so really making sure this is much more relevant in our setting. And in terms of implementation, again, we ended up having to do this virtually, but that was a blessing in disguise in the sense that The pandemic happened. We all needed to isolate, but by being able to be in a virtual setting, we actually were able to get all the different interdisciplinary facilitators in the same space, because if we have campuses all around, it would be really hard to get everyone in one setting just to help facilitate workshops for anesthesia and surgery residents, especially when you're not coming from it. But I do think there's value when the residents are seeing that an emergency medicine attending is making space for them, as well as a pediatric attending or an internal medicine attending or an otolaryngologist. Everyone is coming to our space, making space to talk about this very important topic. And I think the residents see that there is value in this because of so many people are coming to the same space to have this conversation with them. And so we did this for anesthesia and general surgery residents back in 2020, and we've expanded it to orthopedic surgery residents and ophthalmology residents. And now it's actually being expanded to otolaryngology residents as well too. And so trying to figure out our bandwidth in order to accommodate the more requests that are coming in order to do this. We have house rules. And so some of those house rules include assuming positive intent, keeping confidentiality in our small groups, just setting the tone for people to be able to share without fear of repercussions so that we can really do facilitate growthful conversations. And these exercises that we have in our small groups were roughly about 20 to 25 minutes for a 2-hour workshop in itself. And again, remember, we did 3 different workshops: 2-hour workshop on unconscious bias, a 2-hour workshop on allyship, and a 2-hour workshop on microaggression. We had, again, those case scenarios and, again, large group debriefs, as well as self-reflective exercises. Now, I also created space for a post-workshop survey within the workshop, knowing that our residents are quite busy. Now, let's look at the results of these workshops. So in the unconscious bias, allyship, and microaggression workshop, I asked a general question, which was, did this workshop show you that the DEI curriculum was important in your training? And you can see for each of the workshops, over 90% agreed. Also, over 90% believed that the workshop was relevant to their workplace, and over 90% recommended that this workshop be given also to their peers. Now, in terms of qualitative themes, when I asked about the unconscious bias workshop, what did they like most about it? Oftentimes, we got about 19 responses that said that they really appreciated the small group breakout sessions and that they really liked the interactive and engaging exercises. When they asked, or when they were asked what could be improved, they actually wanted more time in their small group discussions. And so the other iterations of the curriculum have involved more time in their small groups, with the hopes that there's more satisfaction and also more time for growthful conversations. Because once you get them started talking about some of these concepts, they finally, when the intimidation starts wearing off and they really feel like they're having growthful conversations, that's usually when the time is interrupted for them. And so really making sure that we give people time to kind of de-effervesce and get into those spaces of growthful conversations before we cut them out when they're getting into the heat of it all. When asked for the allyship workshop, what they liked most, again, same thing, small group breakout sessions, they really like that. They felt, and these are their words, safe space for open conversations and discussion was one of the things that were quoted. And then what could be improved in a workshop? They wanted even more time. They wanted less lecture time. They wanted less didactic time. So in essence, we did the same as well too in those workshops. And then also for the microaggression workshop, what did you like most about the workshop when we asked? They said learning about practical tools and skills, the role-playing scenarios were helpful. And then when asked what could be improved, they wanted more resources for responding to different microaggressions. Some of them said that they didn't really want anything in terms of improvement. And then in terms of our quantitative results, basically, we did a pair t-test analysis for over the 5 Likert scales in different statements around unconscious bias, allyship, and microaggressions. For the unconscious bias workshop, I think the thing that the statement that resonates the most with me is that before the workshop, you had some residents say that they thought that their unconscious biases affected clinical practice, and then you saw an increase in them believing that and more strongly agreeing that they felt that their unconscious biases really did affect their clinical practices and interactions with others. And half of the battle is the awareness and figuring out that you have it so that something can be done in order to help mitigate it. And so that was really powerful. The other component was the microaggression workshop. And again, we did a parity test parity test um, analysis with these statements around microaggressions in terms of self-reported confidence and skill acquisition. And if to me, again, this most important statement that I took away from this is that even though there was an overall increase, the fact that the trainees felt that they had the tools to address the microaggressions that they witnessed was incredibly powerful. And again, very little compared to very many at the end, I think was just really important there. And then last but not least, as we're thinking about true allyship actions, is um, the shaping of policies through our respective institutions and professional societies. I think that institutionally, we were able to implement a DEI curriculum where we otherwise would not have had that. And it took a lot of pushback, but then finally the opportunity to sponsorship to say, yes, let's just give you the opportunity. No one else is doing it. Let's see what happens there. And basically now this has become something that we've done over the past, now we're on our going into our fourth year in 2024 of doing this. So I really do want to highlight that these true allyship actions, again, not necessarily benefiting us, or we don't see it yet, but it really is about just lifting and giving people those opportunities. And then who knows, at the end, it actually ends up does benefit the larger pool in general. Now, the other component within our true allyship actions that I'd like to speak to in my role within UCSF is that I'm incredibly proud that we've also been able to hire a DEI and culture director. This is someone who's doing the work in our initiatives literally every day, as opposed to the allotted time in my point 2 FTE to try to do this over a large department. Again, just like Stanford, we have well over 500 members within our at least within our anesthesia department. I'm not sure what it is, the composition is within our surgery departments, but within large departments, we really need the legwork, we need the support, we need the resources in order to be able to enact true allyship action. So I really want to highlight there's a picture of Leah Pimentel there and all the fabulous work that she's been able to do. And that's where I'll probably end it. I think that we've been very fortunate to be able to enact many different initiatives, whether it's around well-being, because well-being and DEI are very interconnected. My partner in crime is Dr. Gina Sinsky, who's been incredible to work with in order to kind of align some of the goals around DEI. And then also creating spaces for people to provide feedback so we can constantly figure out what else needs to be done to improve our environment within our department as well as our institution. So in summary, again, I will say that when we think about allyship actions, we should be thinking about how we are promoting recruitment, and that could be pathway programs, that could be intentionally looking at taking a second look for our applicants. It can look at sponsorship, it can look at mentorship, it can look at institutional policies that are being shaped, whether it's diversity training that we're asking folks to participate in, or making sure that we have a formulated diversity community. All right. And on that note, I will pause there and see if there's any questions. Thank you so much for your time.